I'm Dr. Rose Cheng. I'm a perinatologist and I deal with high-risk pregnancy women.
Hi everyone, I am Dr. Sarapuddin. I am a neonatologist and I take care of babies delivered prematurely.
Okay. Most of the time in the clinic, we do get a lot of questions and cases about preterm birth, which is why today we're going to be debunking prematurity myths. Next.
Okay, premature babies cannot breastfeed exclusively. Well, that's a shame. Preterm babies can actually breastfeed exclusively. So exclusive breastfeeding means giving your baby only breast milk. So there are other ways of giving breast milk. Of course, when they are born prematurely, they are fed through the tube, like orogastric tube. Once they are more mature, they develop their suck, swallow, and breathing coordination, which is around 34 weeks. Then you can have them latch on your breast. So it doesn't always mean exclusive breastfeeding is just on the breast. It means giving your milk, your breast milk to your baby.
Source, I will just ask, you said
Yes.
34 weeks, then they
Right.
can start latching. Is there a particular birth weight or achieved weight while at the NICU that they can already start having the mom latch the baby?
Actually, as early as when they are born preterm, even at 24, 26 weeks, just to be placed. Well, of course, given they are medically stable, you can put your baby, you can latch them. It's not really for the latching or for the sucking. It's more of bonding. Your baby will be familiarized with your smell. So even as early as long as they are medically stable, then you can have them latch. The sucking, the swallowing actually develops around like 28 weeks of life, but it's the coordination that is around 34 weeks. So at that time, you can have them latch and have them like suck on your breast.
So mga mommy, it's better that you still visit the baby.
Right.
Kahit nasa neonatal ICU, kahit maliit si baby, visit pa din because I'm sure Dr. Sarapuddin will allow you to carry baby.
Yes.
Right? Okay. Next, I need to have an ultrasound to know that I'm having preterm labor. Okay, the answer to this is not all the time. Us physicians would always say that there's such a part of history taking that includes physical examination. So sometimes we will be pressed for time, there's no time for an ultrasound to be done. If the patient is eligible for an internal examination, wherein the OBGYN will check the cervix, if it's dilated or not, that's already one criteria to mention or to tell a patient that she's in preterm labor. On top of that, if the abdomen is showing signs of contractions, or the patient can actually sense all of the signs of preterm labor, then we don't need an ultrasound. But there's this population of women wherein they have an incompetent cervix, they will not feel anything at all. Then that's when the ultrasound will play a huge role because the ultrasound will be able to measure the cervix. And there's a normal cervical length and there's an abnormal cervical length that will make the OBGYN decide if she will label that patient preterm labor or not. There. This one is for you.
No, I think that's yours.
This is for me. If I am diagnosed with preterm labor, I will have to stay in the hospital until delivery. Okay.
Expensive.
Yes, frequently asked question. But this is actually quite hard to answer because when we advise our patients, because they are admitted for preterm labor, we don't offer as much as possible empty promises. Uy, misis, after 2 days, uwi ka na. Cannot. Because the first step is always to identify what's the problem, what caused the preterm labor. Now, the problem will be the one that will dictate, will I be able to send this patient home or not? So it's a whole spectrum of risk factors and reasons why a preterm labor will be triggered. Well and good, if it's just threatened preterm labor, that means the cervix was never really dilated, the contractions or the infection was controlled, most likely we can send them home. And we have advanced management techniques wherein a patient can be sent home either with something that was inserted or a medication that the patient will just have to maintain. Down the line, the poorest of the poorest prognosis is when the cervix on internal examination of the OBGYN shows that the cervix has dilated at a very advanced way. That might already be very difficult. So we will give Dr. Sarapuddin and all our neonatal ICU staff a heads up that this baby might come out already And that patient might also have to be told and advised that she'll have to stay until prognosis is better or until she might likely have to be really delivering. Most of the time, we also want to make sure that the medications to help delay the progress of preterm delivery is instituted. The solutions to prevent preterm birth are known. Okay, again, solution is like if you have a wound, you clean it, put a band-aid, it's a done deal. It's not that case for preterm birth and how to prevent it. I'd like to think that maybe there are measures to help make sure that you are not going to be at risk for it. So it's more of trying to prevent that you be at risk for it. Definitely, if you're going to give me a patient who is a multiple gestation patient, I don't think there's a way to prevent that.
Right. Yeah.
But let's start with lifestyle. Once a patient expresses her desire to get pregnant, we do preconceptual counseling. And the first thing we always mention is please stop smoking. So if you are smoking, please stop, because it's one of the risks and it's one measure to prevent. But will it prevent the entire problem? Cannot promise. There are certain women who will be born with an inherent incompetent cervix. Can we prevent preterm labor for such cases? Most likely we may be able to, because we have ways by which we can tighten that cervix. So for that, we may probably be able to do. But in essence, if we're just going to plain and simple answer this question, you'll have to have that discussion with your OBGYN, because your OBGYN will weed out all of your risk factors and address each one question one by one. Okay. And
Okay.
this is you.
This is me.
Yes.
So, your journey ends once you leave the NICU. So, having a NICU graduate, that's an amazing milestone. So, leaving the four walls of the NICU, yay, we're done. But I think we have to consider that having preterm delivery, traumatic delivery, and a long stay in the NICU, it actually has a lasting physical and emotional issues for both the baby and the parents. And in fact, more than 50% of parents who have preterm baby, they have a risk of developing depression, anxiety, and in fact, dysfunctional families. So, I mean, these are grim, but it tells us that we have to ensure NICU awareness and, of course, support group. So, awareness and support group, so this should start while they are in the NICU and not when they are discharged already. And over the years, research has shown that the parents' mental health is as important as the medical care of the baby.
Sounds good. What I was about to add to this is the journey also doesn't end for the parent, particularly the mother, because just as I mentioned a while ago, once this patient who has given birth to a preemie or a preterm birth baby, then the likelihood of her achieving another pregnancy might put her at risk again. So here at Medical City, we have the preterm birth clinic, wherein women who are wanting to get pregnant or already pregnant or have just given birth can come and seek counseling. And that will include Dr. Sarapuddin as well. They will be given a bird's eye view of what they're up against, and if there's anything that we can do at that point that will make them come up with a quite better journey from the last experience, so that it's not entirely traumatic.
Right.
Yeah.
And I would also like to add that, of course, you can never be ready for a preterm birth, but at least having the idea of what to expect, somehow it eases you, and at least you can somehow prepare. So I think that's very important as well.
This is Dr. Rose Cheng.
And this is Dr. Soraya Sarapuddin.
We are from the Medical City, taking care of you.